Hey guys, we're going to talk a little bit about basic fetal monitoring. Fetal monitoring is really the only tool we have to assess a baby before it's born, the only reliable tool that we have. So the information we get from it is limited. We have to be really careful in how we interpret it. But this is just the basic stuff. So we'll learn how to use external and internal fetal monitoring to assess fetal well being and uterine activity. We will learn how to identify the baseline fetal heart rate, baseline heart rate variability, and episodic or periodic changes to the heart rate. We will learn how to assess contractions or uterine activity using a combination of fetal monitoring and palpation. And we will learn how to interpret the data we obtain from fetal monitoring to make informed decisions about the care of the antepartum or interpartum client. So, this is some of the equipment you have. This machine right here is the monitor. You'll see the paper comes out. I'm going to explain how the little blocks work. Here's somebody on external fetal monitoring. That is your ultrasound transducer. That's what captures the baby's heart rate. You're not actually hearing the heart rate as much as the ultrasound is interpreting the striking motion of the heart. And then you have a TOCO dynamometer that measures uterine activity. It has a pressure sensitive button. It can tell us when contractions happen. It can tell us how long they last. It cannot tell us about intensity. So we'll talk about that when we get closer to monitoring uterine activity. Okay, so here's internal equipment. Now, internal equipment is much more invasive, so it is less preferred, but it is more precise. Membranes have to be ruptured. The patient has to be dilated at least a centimeter for internal leads to be placed. But it does give you very, very accurate measurements. This is the internal scalp electrode right here in the top left. You'll see there's a little cable, little wire. It's like twisty. This hard plastic thing does not stay in the mom. It just kind of guides it so that you can get to the baby's head and twist clockwise to kind of screw in this tiny, tiny little wire into the baby's scalp. You have to avoid fontanelles because you don't want to puncture anything that's open like that. And it will give you beat to beat like an EKG of the baby's heart rate. Now, over here, we have on the right an internal uterine pressure catheter, and also called an IUPC. It hooks into the same monitor that does the external monitoring, but there's this semi-rigid, it's a little bit flexible lead here, and that can sense the internal pressure of the uterus. So it tells us not just about how frequent or long contractions are, but it tells us more about the actual intensity of those contractions. It measures it in millimeters of mercury. This is also invasive. So again, we don't use it as often. I want you to also notice here on the side of that IUPC is a little port where we can hook up fluids if we need to do an amnio infusion if baby's having trouble with the strip. And I will talk more about that when we talk about variable decelerations. Okay, so we have here the fetal heart rate. I'm going to play the strip. So you can see that's what it'll usually look like. I'm going to pause it for a second. I want to call your attention to these dark red lines. The space between each of these dark red lines, from one red line to the next, that is 60 seconds long. The lighter red lines, 1, 2, 3, 4, 5, 6, are 10-second periods. Okay, so that's how your paper is graded. Dark red lines a minute, light red lines are 10 seconds. We have the baseline up here. Now, you'll see it's kind of jumpy. We'll discuss that with variability. But normally for a baby, it's going to be between 110 beats to 160 beats. That's our top line. Now, there are changes in the heart rate. The baseline is between contractions, usually, and it's an average, and it's always reported in multiples of 5. So it could be 110, 115, 120, 125. You're never going to report the baseline as 122 or as a range. It's always going to be in a multiple of 5 per NICHD guidelines. Now, I'm going to play it a little bit longer so you can see. And when I freeze it, we get about 10 minutes of strip. Hold on. Let me get back to it. And I'm going to show you the uterine activity. So let's back that up a little. We time contractions from the beginning of one to the beginning of the next. So let's get, beginning of one is here. We go 1, 2, 3, 4, 5, 6, 7. We're at about 7 minutes apart with these contractions. And how long do they last? 1, 2, 3, 4, 5, 6. So they're about 60 seconds long. Intensity, if this were a woman who needed external monitoring, or we were doing external monitoring, we would feel her uterus at the fundus, and that would tell us if it feels like the tip of our nose, it's mild. If we indent to the uterus, it feels like our chin, it's moderate. And if it feels like our forehead, it is strong. Okay. And I'm going to go forward in time a little bit. All right, so baseline fetal heart rate, normal 110 to 160, just to repeat ourselves. If it's greater than 160, it's tachycardia. The most common cause of tachycardia is fever, but it can also be fetal distress. Bradycardia, lower than 110 beats per minute. Sometimes that signals a congenital heart problem, and sometimes it could be a baby who's sleepy. But generally, bradycardia is not good. It usually means fetal hypoxia. Indeterminate means the baseline fluctuates so widely that it's impossible to pick up a single number. And we'll look at strips that look like that. Baseline variability. So now we know what the baseline is. How much does it vary within a 10-minute period or whatever? So these are irregular fluctuations in the baseline fetal heart rate. This is the most important characteristic, I would say, most of the time, of fetal heart rate. Variability, that jaggedy edge that we saw in slide 5. Okay, see how that line bounces up and down? That is moderate variability. That is a result of the push-pull effect of the sympathetic and parasympathetic nervous systems, and it generally indicates when it's moderate that our baby is healthy and neurologically intact and does not have any hypoxia. So the nervous systems are working together to oxygenate that fetus on a moment-to-moment basis, responding to little tiny changes. So we can categorize baseline variability in 4 categories. We have absent, which is up here. If you see that real flat line, that is bad. It is acidemia caused by lack of oxygen to the baby. We hate absent variability. So that is grossly abnormal. Here is minimal variability, the second one down, and that has some amplitude, like 1 to 5 beats per minute between the beats, but not enough. Now, sometimes small periods of minimal variability are just from fetal sleep or maternal medications like opioids for pain relief, or if we're giving mom magnesium sulfate, something that would sedate the baby can cause that. But this is a baby who's not moving around. This is a baby who's not responding. So if we don't have a better explanation, we're usually thinking that there's insufficient uteral placental blood flow. And we don't love minimal variability. So moderate variability, again, that jumpy line. See the difference between this line and this line and this line? We have a lot of jumping up and down between the beats. This is an oxygenated fetus. He's neurologically intact. We know that he can respond to changes in the demand for oxygen on a moment-by-moment basis. We are not that concerned about a baby who has moderate variability unless we have other reasons. And here we have marked. Remember I talked about that indeterminate baseline? This baby is struggling to find a baseline, and the difference between the rate and the beats could be more than 25. It could be really wild all over the place. That's not a good sign. It's not a place where more is better. So we could be looking at cord compression. We could be looking at hypoxia. Sometimes we're looking at tachysystole, which is hyperstimulation of uterine contractions. Babies don't respond to that very well. So let's do it again. Absent variability. This is bad, 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 very, very bad. When I see this, I get very, very nervous. The amplitude over time, there's not any fluctuation. It's undetectable. It's so smooth, like you drew it with a pen. Minimal variability could be bad, but brief periods can mean fetal sleep or maternal medications that sedate the baby. So this is an amplitude detectable, but it's less than or equal to 5 beats per minute. And you see it still looks pretty flat, but there is some amplitude. Moderate variability, normal, reassuring. I see this. I know that I could give report to my friend and feel good about that baby. Um, Amplitude here is between 6 and 25 beats per minute. And you see it's kind of jaggedy, a little irregular. That just means baby is responding. And lastly, marked variability. This is like, I think this is a simulated program because you rarely see it look this clearly drawn. But the baseline heart rate, you really can't almost pick a baseline because the beat to beat variability is so very different. Okay. So we're going to cut this off here, and then we're going to move on to episodic and periodic changes.